Apologies from Julie Holder, Simon Jordan, David Moon, Dame Julie Moore, Andy Parker, but Cinder is with us, and we have apologies from Joe Rouse. And at the moment we have apologies from Glenn Burley, who's disappeared. Not sure why. Any new declarations of interest? Can you please raise a digital hand for me? Okay, I do have a new one on my declarations of interest. It refers to my son working for Deloitte. He's resigned from Deloitte, but is about to become head of strategy for GB UK, which is a medical devices supplier. So that will represent a change in my formal declarations of interest. The minutes of the meeting held on the 7th of February. If you weren't happy with the accuracy of those minutes, could you please raise a digital hand for me? Okay, I can't see any digital hands raised, so I will take those as accurate. So we'll move on then to the matters arising, and we go to page 20 of the digital pack that we have. And first up is the work on equality, the NHS Equality Delivery Scheme. Thank you, Gertie, Jeffrey and Ali for your work on that. And I should just mention, this is Gertie's last full board meeting with us. Gertie will be leaving us in July for pastures new. But whilst we're all together, Gertie, just an enormous vote of thanks from all your colleagues for all your hard work over the last few years. You will be greatly missed, but we're pleased for you to be able to go close to home with your family. Next up was, and these are all actions in progress, the managing directors to ensure analysis takes place to compare cancer diagnosis from ED attendance across each trust. When do we expect that to be included? We were saying in the May 2024 report. Catherine?
I can include it now for you, Russell. So I've put the chart in the text for you. You'll see that Worcester and Swift all have roughly similar numbers, but George Eliot is an outlier. I think the next piece of work is to correct this or see if there's a way we can make an adjustment for deprivation, because we know that deprivation is linked to late presentation of cancer, and I think that's an important confounding factor we need to do. And I think there's some work for us to do at George Eliot to take this back into our clinical and professional partnership group at Warwickshire North Place to do a bit more analysis into why we appear to be an outlier in this this area. So it's useful data.
Okay, well, can we keep it on the action log, and then you can keep us updated, please, Catherine? And then next is a deep dive into additional performance measures around theatre productivity. When do we expect that to sort of bear fruit, my Chief Operating Officer colleagues? Do I have a volunteer? Robin, thank you.
Kamal and I put around at the same time. Yeah, we're working through theatre productivity in line with the deep dive schedules we've got, Russell. So we've got a deep dive on urgent emergency care for this meeting, and with theatre productivity we'll pick up at the next meeting.
Okay, great. Just for members of the public who are joining us today, and it's lovely to see so many of you with us. Productivity as a focus, driving productivity is very much at the centre of all of our thinking across all 4 boards in the foundation group. So thanks for your work on that, team. And then also with the Chief Operating Officers to look at the variations around theatre. It goes back to the previous point, Robin, so I think that last one is in hand as well. And then we talked about from the CPOs that the 3 services in the EDS report captured citizens from groups which were harder to reach. When do we expect that to be completed, Gertie, Jeffrey and Ali?
I think we could mark it as complete, Russell. The EDI leads are working together across that and sharing good practice so that we're acting as peer for each other in the assessment under the new EDS 2022.
Okay, thank you very much. We'll all keep an eye on that. So this morning, again, just for members of the public, we had our board workshop, and it consisted of a 4-part board workshop. The first was we had 30 minutes with Sir Jim Mackey, who used to be Chief Executive of Monitor and NHS Improvement. Arguably, with our own, one of the very top chief executives within the NHS. And we talked about the sort of future outlook given an election coming this year. And Jim very much counselled us to carry on doing what we were doing in the foundation group of identifying and sharing best practice at pace, with a particular focus on integration at place and on productivity. So Jim started us off. We then had a session on the work we've been doing on integration of our flexible working across the organisation. The phrase we're using is yes to flex. And Gertie, Jeffrey and Ali talked about the work we've been doing there to try and provide the most flexible working arrangements for our colleagues to ensure that they want to stay with us and find us one of the best employers within the NHS. And we touched on some of the results which in the individual boards we've talked about on the staff survey, which shows that across the NHS we are making good progress relatively. And then we had a session on our work on integrating within SWIFT, the community recovery services, and down at Hereford, the Better Care Fund work to try and improve discharge and flow across those two trusts, and talked about the learnings possibly in other areas as well. Flow for members of the public is absolutely essential for us to be able to minimise length of stay in each of our acute settings. It really doesn't benefit patients to stay in hospital when their acute episode is finished. The evidence for hospital-acquired functional decline is very strong, so we're doing a lot of work to make sure patients can go home with the help of their families, community groups, as well as local authority and social services as quickly as possible. So across all of our localities, we're doing a lot of work there. And then finally, we had a weighty session on our legal responsibility from our legal partners, Waitmans, which was very important just for all of the board to understand our individual and collective responsibilities. Glenn, do you think I've missed anything in that summary?
No, you covered it well, Chairman. I think certainly for me, the being a very flexible employer element of it and the staff engagement, you say linked to the staff survey, is probably going to be one of the biggest drivers for this year's productivity push. So it's going to be a big thing across the NHS, and I think that we're well placed on that. I think also when we look at the performance dashboards later, the improvement in pathway 1 domiciliary care discharge to assess is definitely a part of the improvement story around A&E waiting time. So I think it's good to see that coming through in terms of better flow in our results as well. So you covered it well.
No, thank you, Glenn. Any questions from board colleagues on that overview of the discussion we had this morning? Okay, we'll move on then to the performance reviews and updates. Again, for members of the public maybe not familiar with the way these board meetings work, we do choose to do an overview initially of an apples by apples comparison of certain key performance metrics. It might sound obvious, but members of the public might be surprised to learn that actually getting the measures of even something like length of stay to be apples with apples as a comparison across trusts is surprisingly difficult. So we use this initial part of the 4-group board meeting to discuss that apples with apples comparisons, and then we do a deep dive into certain areas, and that's what we'll go on to next. But initially we're over to our MDs, and I will ask Jane to lead off, please. Jane Ives.
So usual format that we've done in this is to try and take a few areas to comment on for each organisation. So I'm not going to talk about urgent care because we've got a deep dive on that later. So the three areas: one thing I'm concerned about, one thing that we're watching, and something I'm proud of. So those are the three areas I'm going to take. So firstly, in terms of concern, still concerned about theatre productivity. It is an improving picture. I mean, broadly over the year, it's gone from about 75% to 80%, but we need to be at 85% consistently. The other part of that is theatre usage, actually. So utilisation to the theatres that you use and how much of the operating time you're actually using operating. But the other is usage of your funded theatres. How many theatres are you actually using, so they haven't been cancelled? And we've actually made a quite significant improvement on that, which means that the number of cases we're doing has improved. But utilisation is something that we're really concentrating on to make sure that we shift that to 85%. The thing that I'm watching is around sickness levels. So in one sense, it's a good news story because it's at 4%. I think that's the lowest the organisation has ever been. But one swallow doesn't make a summer, and again, it has been coming down. But that 4% is something that we want to set as our benchmark now, because that's much nearer the place that we want to be. There's been a lot of work gone on around how we support our staff health and well-being, how we train our managers, how we make sure our policies are right, so this is and we've also made a number of investments both in our HR teams and also through our charitable funds, again how we support staff health and well-being. So we think it's multifaceted, but all of those things come together, and we've seen a drop. The watching bit is making sure that we stay at that level and we're getting the return on the investment that we've made. And then the third thing for me is the thing I'm proud of, which is around cancer performance. So really great to have met the faster diagnosis standard for February and actually for March, which that data isn't in this report yet, but that's exceeded the national target for in fact until March 25. So that's really good. And also the number of patients waiting over 62 days. We had a target for the year of 71 and we came in at 56, so exceeded that. So both of those things mean that our current 62-day performance, which was 63% in March, we are the national target for next year is 70% by March 2025, and we are expecting that we are going to exceed that over the course of next year, because there's a lot of both capacity improvement and process improvements, which mean that those we don't feel those are flash in the pan. Those are sustainable improvements in our cancer pathways. So something we're proud to talk about.
That's great, Jane. And I am very conscious, and this is true across all of the foundation group, the enormous increases in demands and pressures into our ED department. So can each of you take back the message of thanks to that. And as we move on to Adam, some really pleasing performance, and congratulations, Harkema and team, on our operational performance in March and what that meant relatively. Adam, over to you.
That's an excellent segue, Chairman, because that's where I wanted to start with talking about ED performance in March. So just to set in context, I think it's been a really challenging year at the front door of the hospital. So we started last year in a position where 300 attendances in our ED was pretty much unheard of. And through the year, we went through it being a relatively common occurrence to it now being really quite routine. And I think that shows the increasing demand and pressures on the ED team. That said, the team have coped with it excellently. And in March, we ended as one of the top performing trusts for 4-hour performance, and we maintained our standard for ambulance handovers as well, which is I think really excellent. And supports the approach we've really taken of looking at flow across the hospital to support performance in ED, and certainly with the winter schemes we put in place. They were very much about smaller schemes that supported marginal gains in performance for flow in the community, in the wider hospital, and it's really paid off. We should therefore, subject to confirmation, be able to access capital both for being a top performing trust and for the improvement we saw between January and March, which is really great news and a great validation for the work of the team. So that is what I'm really proud of, and certainly thanks to Harkamal's team and the wider operational teams and ED teams and teams across the hospital for getting us there. In terms of other areas, where we are being really watchful at the moment is cancer and diagnostic weights. So we're slightly below the trajectory for the 62-day standard, and we are below where we want to be for diagnostic weights, and that's particularly driven by really high referral numbers we've seen over the last year. And also performance in our non-obstetric ultrasound. Having said that, for both 62 days and diagnostic weights, we've seen real improvements over the recent months, thanks in part to investment in staffing, some really positive recruitment we've been able to do. But this remains an area we're really watchful of to make sure that trajectory of improvement is maintained. Finally, the area of worry I want to talk about is orthodontics and orthodontic weights. So we've done really well in reducing our long waiting lists, and at the end of the year we had no waits over 62 weeks apart from for orthodontics, and there is a national issue with recruitment to orthodontic services. We have been working with the ICB and NHS England with these services. We recognise we haven't got the capacity to get through the waiting lists, and we have asked for support. Now, in the last week, we've heard some positive news that there are some providers that may be able to help us. So we are hopeful that in the next month or so, we'll be able to work down those long waiters for orthodontics. But certainly at the moment, it is our biggest area of concern in terms of waits. Those were the key points I wanted to highlight today, Chairman.
Thank you, Adam. We'll come back to general questions later, but it's probably worthwhile on the orthodontics thing, me just emphasising for members of the public, there is an enormous problem with the provision of NHS dentistry services, particularly to children nationwide, which is extremely concerning. And so by the time if you're not able to get NHS dentistry, you end up in an orthodontics department. Things have become very severe, and as Adam said, there's a capacity issue there. But the starting point is earlier in the dental health cycle and the lack of NHS dentists that exists across the country, which is a national concern. We'll move on then. Thank you, Adam, and we'll take questions at the end of this section. Over to you, Catherine, for the George Eliot, please.
Thank you. So like Adam, I would like to start with the emergency performance, and it was great that we were able to meet the 76% or exceed the 76% standard for the 4-hour performance. That was, again, as Adam said, under challenging conditions, and I think what we didn't see significantly improve was the delays in people waiting for admission who required a bed in hospital. And we saw 245 12-hour trolley waits in the month of March, although that was a slight improvement on the month before, and the month before that. We were used to seeing 0 12-hour waits in the organisation. So the bed occupancy and the challenges of getting people through the organisation persisted into March. But great to see some improvement in the ambulance performance, which has improved further into April. I think the teams are working incredibly hard to deliver the standards that they are doing at the moment, and more work to do on that. In terms of the mortality, I must just tell you that that shimmy of 110 is within the expected range, not red as shown on there, and that's fallen further in the next reporting period to 109. And we heard at our Quality Assurance Committee that our HSMR, which is another indicator of mortality, was also within the normal range, and that is the first time in a long time that both of our mortality indicators have been within the expected range. So really pleasing to see that. Also pleased to report an improvement in our cancer 28-day referral to diagnostic confirmation. That has been an area we're struggling with, and in terms of earlier in the year, around December time, we were one of the worst trusts, if not the worst trust in the Midlands at that metric. So a huge thank you to all of the teams who've worked really hard at now meeting that standard, and further work continues in that. We have seen an improvement in patients who are waiting 62 days for treatment. That fell from 57 to 37. We've still got further to do because that's just too long for people to be waiting, but a lot of work is going on in that area. In the RTT domain, we have got a reducing number of patients now who are waiting 52 weeks for treatment. We hope to eliminate patients waiting 65 weeks or longer by the end of this month. The national target for that is by the end of September. So we will be really focusing on those patients who have been waiting over a year for treatment, and hope to see that number coming down. Colleagues at George Eliot will know that we opened 2 new wards in April, which means we can co-locate all our surgical services together. That is allowing better flow from theatres into the wards, so that patients can recover on wards, not in our operating theatres. And that will have an impact not only on the number of patients that we're able to treat, but also on some of those theatre utilisation metrics. So we expect to see improvement in those too. And both in terms of theatres and the outpatient work, we have our significant improvement projects focused around theatre utilisation, theatre productivity and outpatient utilisation. And we've seen that improve throughout the course of the year, and we will continue to focus on that so that we can be comparable with others in the group. Thanks, Russell.
Thank you, Catherine, and really great to get those wards and theatres open. Last but not least, Stephen, over to you on Worcestershire, please.
Yeah, thanks. And just a couple of bit of context for the performance that I'll talk through were 2 bits in terms of the work that the trust has been doing around its financial run rate and trying to improve that. And the other bit is the CQC. So Sarah's teams led a really good review by that team of critical care. So against all of what I'm about to talk about, there's a lot of other work going on there. Just in terms of urgent and emergency care, we've seen improvements across, similar as others have described. Really pleasing is the reduced handover delays, and particularly those protracted ones that we'd had at Worcestershire for a long time. Just for note for the board, and it may be something that we come back to and it's not covered in the deep dive, we saw a high risk number of attendances through the department, and in particular was walk-ins. So there's a piece of work that we're doing with the ICB in terms of an attendance audit to look at what lessons we can learn and what gaps there may be that we can address that. In terms of cancer, in terms of our 62-day backlog, I think when we talked before, we had over 400 patients that were waiting over 62 days. We've got that down, as you can see, and we've gone under our target of 190, and it was really pleasing for the staff to receive a letter from the National Cancer Team, because I think our improvement had actually moved the national cancer numbers. So that was really good for the team. And in terms of RTT, I think last time we had over 150 potential breaches over 78 weeks, and we brought that down to 27. And there's a really firm plan around eliminating those by July. And I think a shout as well to the work that's going on between ourselves and Wye Valley around those fragile services, that I think is really going to put much more robustness into those for both trusts actually, and strength of the group. That's all I wanted to bring out, Russell.
No, thanks, Stephen. We're making good, solid progress at Worcestershire, which I think is being recognised regionally and nationally. So questions and perspectives on what we've heard on the other bits of the performance report. Glenn?
Yeah, I mean, it's particularly nice to get that letter. I've got a small folder of thank you letters from NHSE, and it was nice to get another one to add to it. I mean, I think it's really important when you look at across the board at the performance of the trusts in the group. It's good to see some really encouraging numbers, despite a media narrative about where the NHS is, and particularly it will be a tough media narrative over the next few months, I'm sure. So let's keep that incremental improvement going. I think one of the areas that stood out for me in the pack was the theatre start time analysis. So, despite actually trusts in the group generally being topping the charts in the region in terms of elective productivity, there's clearly some opportunities for us to do better in terms of theatre utilisation. And probably for the public looking at this, to see that we're starting theatres late, we'll probably think, what are we doing here? And I think Stephen and I were in a conversation with the consultants at Worcestershire Acute this week, where it's not about people necessarily being late for theatre. It is about not having that first bed available for that first patient. And I think we need to get into a discipline of starting the case, finding the bed, because the bed will come up, and our processes we need to trust to happen in place to do that. So I think a bit of a push for everyone on absolutely maxing out that theatre productivity, because this is what's going to help us to reduce those long waits for patients.
Absolutely, Glenn. Theatre productivity and driving flow and discharges is very much what all of our operational actions are about. Any other questions or perspectives to the team? I think just to reinforce what Glenn said, I think there's an awful lot for us to be proud of as we end 23-24. We have sort of delivered the financial numbers that we said we would, which is important. At the end of the day, we're only as good as the numbers and the care we provide to our patients. So long may that continue, but lots to go after. Are colleagues happy, therefore, to move into the first deep dive? So our first deep dive is into urgent and emergency care to pick up virtual wards, length of stay, demand, management, and discharge to access. So basically everything. So I'm not sure which of my coups are going to lead off. I assume Harkamel, given the running order, or not?
No, actually, Helen and Robin are going to do this one for all four of us.
Okay, super. So Helen and Robin, over to you.
Okay, thank you, Chair. I'll kick off and do the first half, and we've got a few slides just to annotate some of the conversation. If I may share my screen, try and work with technology.
You can see that.
Okay, excellent. All right then. So, as always with these, through the group that we've got set up within the ops group, we work together closely on a whole range of topics, and this was the latest one that we were asked to look at. We've tried to condense it down slightly because, as you said, Chair, urgent and emergency care covers a whole range of different things. So the areas we focused in on this time are around attendance avoidance, emergency department and SDEC flows, the admission pathways and inpatient pathways and discharge, linking through to our virtual wards. Keep your slides moving. So on this slide, what we can see that the levels of activity coming through our EDs, and Worcester, you can see there with the green bars, Worcester having the highest collective total in comparison to the other sites, but noting that this includes Worcester, Alex and Kidderminster activity as trust as a total. So still high volumes of activity, and we can see by the centre chart there that we've got our A&E attendances per 1,000 population, and actually when we look at that, those type 1 attendances, actually that changes the picture slightly, and we can see that Worcester have got the lowest attendance numbers per 1,000 population. So again, looking at the data in different ways gives you a different analysis or different snapshot of some of the key drivers in what drives our pressures by site. And we can also see there our ambulance walk-in activity and the split there, with a noticeable difference between Swift and George Eliot versus Worcester and Wye Valley. So split potentially in the ICB system demographics and work going on in each of those systems. So, and Helen will come on in the second half of the presentation to talk about collectively what some of this means and what each of our organisations is doing in more detail.
Robin, sorry, before you move on, can you just explain for members of the public what type 1 A&E attendances are, please?
I can indeed. So type 1 A&E attendances are the more poorly patients that are brought in. They're what sometimes we call them majors, but they're a more poorly category of patients that come into ED. Just moving on then to the next slide, again, you'll see on here that it shows a direct comparison of our 4-hour performance for each of the organisations, and that is then split out by, as I've said, type 1 majors or most poorly patients attending, minors activity, which is our effectively our less poorly patients coming through, and our paediatric activity. We also come through here to look at the scope of our same-day emergency care services as well. And looking here, we can see that the slight difference here on the Worcester line, which suggests that there's potentially more activity from a percentage of emergency admissions that could go through an SDEC route. Also, on this slide, we can see there's potentially an area of focus around minors performance with a slight change or differential between the activity going through Worcester, although we do also note that is heavily impacted on by congestion in the EDs as well. So again, Helen will come on to some more specific actions being taken for Worcester there. In terms of slide 5, this shows us the percentage of our beds occupied by patients that are over 7 days length of stay. And again, we can see that actually Worcester and Wye Valley may be able to reduce some of their delays in inpatient pathways, although when you look at the trust broadly all trusts are broadly comparable in terms of our overall emergency adult length of stay, and actually leading the way there, Wye Valley leading the way with the lowest emergency adult length of stay out of the group. So again, featuring heavily in the work that we do around how we learn from each other going forward as to what's worked well at each of the organisations. So final slide for me is on virtual wards. And what we see here is a comparison of our virtual ward capability across the group.
Robin, sorry to
Yes.
interrupt again. Can you just explain, for maybe people not familiar with the terminology, what we mean by a virtual ward?
Of course, Chair. So a virtual ward is effectively a process and a service that we deliver whereby patients will be discharged earlier from acute care. So rather than sitting in an inpatient bed in a hospital, they're effectively cared for in a very similar way, but in their own homes or their usual place of residence. So it's teams outreaching to support patients, whereas ordinarily they would have sat in an acute inpatient bed. So what this table shows, and we've used a RAG rating to show where we've got services in place, in green, where we've got services that are being worked through, in amber, and services we don't have in red. And it shows a comparison across the organisations as to what services we have in place. And we can see the only common service that spans across all of our organisations is the on there it says IV OPAT service, and effectively to members of the public, what that translates to is the community-based intravenous fluid service. So where drugs need to be given intravenously via a needle, they can be given in the community rather than a patient sitting at home rather than a patient sitting in hospital to have those medications given. So again, this highlights where as organisations we've each focused on areas that have either been driven by need within our local community or need within services within our hospitals, and it shows that actually we've each got different services up and running, and the extent to which we can already learn from each other rather than reinventing the wheel. We can share standard operating procedures and pathways to quickly set up services in other areas within the group using the work that's already been done, thus showing efficiencies from our discussions and the shared learning from the operational group within the foundation group. And on that point, I will hand over to Helen.
Thank you, Robin. So the next few slides now set out for each organisation within the group some of the issues, drivers, improvements that have been made through our urgent and emergency care services, and the activity that we've seen and some of the pressures that we have seen across the last few months, particularly over winter. So I don't intend to go through every single line because I think you can see those, but I'll just pick out some of the key issues, because what you will start to see is an amount of commonality through the organisations around where our pressures are. So just start with George Eliot in terms of some real challenges around overcrowding in the ED department, and you'll see that within Worcester, and you'll also see some of that within Wye Valley as well. We're also seeing higher numbers of patients waiting for more than 12 hours for admission, and Catherine touched on that earlier on, around those patients with that long length of stay in the ED department. And I think what happens there, just as a narrative to explain why that's an issue, is one, that it's not great for patients, because if they need to be admitted, then they need to go to the ward of their speciality as quickly as possible to be cared for by those specialist teams. But also that's a patient in an A&E space or a trolley or a bed that's being occupied for a longer period of time, so that puts delays on then for the patients then that need the use of ED. So some real challenges there, and particularly what we have seen is and again you'll see this particularly at from a Worcester point of view, the challenges around the ambulance handover delays and some of the issues that have caused there. So some of the drivers that we're being seen, and why I'm spending a bit of time more on George Eliot, is because this is the first of some of those themes that we're seeing, is that we're seeing high numbers of patients with no criteria to reside. And what that actually means is there are patients that need some form of treatment or care, but they actually don't meet the criteria for that to be in hospital. So they need treatment and care, but it's not in the hospital that they need that care, but they are still occupying hospital beds. And then the flow out of the whole of the organisation around the numbers of discharges that are occurring before midday, because if you create that flow, then you decompress your ED really early in the morning, and that allows flow. And then those high numbers of patients that have got a length of stay over 21 days. And I think that links to, again, some of the high numbers of the patients with no criteria to reside. And then in that bottom section, you'll see some of the improvements, and there's a really great work that's ongoing, particularly around that system collaboration piece across George Eliot and the partners there. So if we move on to the next slide, Robin, thank you. So from a Swift point of view, many of the challenges and the issues that Swift has around intelligent conveyancing. So that's the amount of ambulances that they see that attend the ED that are from outside of the normal catchment area that you would expect for Warwick. Many of the drivers that are causing some of the challenges for Swift have really been about those out of area patients, and there's some high volumes there, between 40 and 80 per day of patients that really could be seen in another organisation. seeing increased numbers of surgical attendances, but we are still continuing to see, even now, an increased demand for side rooms for infection control reasons. You'll see that in other organisations as well. And so a huge amount of improvements, as you would expect from Swift, in terms of the information, the innovation and transformation pieces around the introduction of clinical decisions unit, surgical assessment areas, and an extension of the GP out of hours slots. And there's a number of other things that they've been doing, particularly around the rhythm of the week in terms of the things that they would be looking at to try and drive that length of stay down. Can you move on? Thanks. From a Worcester point of view, you'll see that Worcester's challenges still remain around the handover breaches that are over 60 minutes, although we have seen a significant improvement in those. They're still not where we would want them to be. And our bed capacity is compromised by sedate flow. So similar to George Eliot around those discharges not happening early enough in the day to be able to decompress ED. Interesting, we suffer with intelligent conveyancing as well. Could you believe it? And when the Birmingham ICBs and trusts are compromised in terms of their activity, much of that activity flows across to Worcester. And one of our biggest challenges is some of our site configuration, because we've made the Worcester site really, really hot in terms of what it can accept, and with how we've reconfigured the Alex site, although it does have an ED, we've tended to use that as the elective hub, but actually it makes the Worcester site really, really hot in terms of that. Many of those drivers we've talked about before around length of stay and poor discharge volumes, particularly around the pathways. And we have high volumes of walk-ins that are starting to come through the door. And the high demand around side rooms. And within there, you'll see we've got a really robust flow programme now, which is starting to address some of the things that we've been talking about across the other organisations. One of the things just wanted to touch on there is that we've had the introduction of a system-wide single point of access, with some really great transformation pieces across both ourselves and the rest of the system. And the national team came in this week to have a look at that and trying to spread some of the good work that's happened there. So I just had to plug that, because it's not very often we get that national recognition from a Worcester point of view. So well done there. And then if we move on to the last slide with all the detailing. So again, similar issues that we're seeing from in Wye Valley around that ED congestion across all of the pathways, and that capacity around their SDEC areas, which is the same day emergency care, to be able to move patients out of the ED into that footprint. And many of the drivers that you'll see in terms of where some of the challenges are, so many of the improvements have been put in, and Wye Valley have done a sterling piece of work, particularly over the winter, in terms of that real streaming, really addressing the miners' pathways and looking at their same-day emergency care pathways and what they can do to improve that, and then the introduction of many hot clinics. And then from the improvement point of view, you'll see the detail there from a Wye Valley point of view of the work that they have done and how much that has improved their performance. So congratulations to Wye Valley for that significant improvement. So if we just move to the last two slides. And what we just wanted to pull out then, because there's an awful lot of information in there, and to be fair, we could have gone absolutely mad with urgent and emergency care, because there's so much to look at. What we've chose to look at was what were the common challenges across the group. So how do we develop that community of practice, and how do we pull that learning together for us? So one of the big things that we're wanting to look at is particularly around our same-day emergency care and how we can learn from each other and improve those pathways. And as Robin said, you know, if we've done it in one place already, can we do a lift and shift in terms of that? So we're really learning and innovating at pace. For all of us, there are out of area issues which not only impact on on our front door performance around conveyancing, but also then how do we repatriate patients back to their home area, and that causes some challenges. We've talked about virtual wards and can we do more streaming to primary care, really, and how we use our connections and our relationships with primary care around using that capacity in an appropriate way. Really ramping up our 7-day working, and how do we deliver that again across the group and learning. And one of the things we just wanted to pick out was we hear anecdotally that acuity is rising in our ED. So we looked at the national benchmark around data. So the higher the number towards higher the number, the higher the acuity is, and you will see that we were all around about the same. Wye Valley's got slightly higher acuity in their department, and I think some of that, Jane, is probably linked to your rurality and the types of patients that you need to see in your ED. So we're all about the same, and that is quite high acuity. So the common opportunities for learning for us, I've talked about same-day emergency care. Where are productivity gains, particularly around improving length of stay, our single point of access developments. We've talked about the outpatient antibiotic therapy and how can we learn from each other. Talking about how we can get better conversations with clinicians by using Consultant Connect, and then that development of our virtual ward offer. And so the last slide talks about what's next. So what we're going to do next. So what we thought would be a great way forward would be to have a foundation group debrief around winter planning and what we can learn, and really what the evidence and the data tells us about how we've managed for winter, because we know actually if we prepare early, then we're in a much better place for next winter. To develop that community of practice across our same-day emergency care and actually learn from each other and understand the variances in terms of the admissions through the same-day emergency care footprints, and then really start to be looking at that demand and capacity focus around our bed modelling and really what that needs to be for us as we start to plan really now for our next winter. So we'll just take any questions then from any of the COOs and Russell, not just me and Robin.
No, that's great, Helen. Really great summary. Thank you. Just before I open it up, just a couple of points I would like to make. The first is to members of the public. When we've done studies of patients arriving at A&E, we frequently find about 25 to 30% of people who come to the A&E don't need to be seen in an A&E. So we would really encourage members of the public to think about alternatives to coming to the busy A&Es. As has been evidenced by Robin and Helen, our A&Es are extremely busy. Our staff are extremely hardworking and often stressed. So anything you can do as a member of the public to avoid an A&E visit, please do so. But clearly, if it is genuinely an accident or an emergency, we are there to help. The second is, which we haven't sort of touched on, is the work we need to do with our colleagues in the ambulance service to ensure only those people who need to come to an A&E actually are put into the back of an ambulance. So with those two contextualization points, other questions or perspectives? Glenn?
Yeah, thank you, Russell. I thought that was a really good piece of work. So well done to all of the COOs for pulling that together. It's well presented as well in terms of the highlight points from it. So and there's some great stuff going on in all four trusts. It's obviously been a week of visits for the single point of access at Worcester, because I visited them this week as well. And they're doing some really good things there, and I think things that we're not doing elsewhere in the group. So I'd encourage other parts of the group to go and have a look at that too. I think on the virtual ward slide, I think particularly for me, it's great to see what's going on in virtual wards and an amount of green on there in terms of whether we have them or we don't. And I think the challenge is, and that was in the summary slide actually, the challenge is how big that capacity is and how big it could be. And so that demand and capacity work is going to be really quite important, because it's one thing having an outpatient prescribing of antibiotic therapy service, but it's another thing, is it absolutely maxing out the capacity that we could deliver the kinds of patients who could be treated at home as opposed to coming to hospital. So I think that's another layer of analysis that would be really quite useful. But it's great to see that, and your performance is showing that this constant attitude that we can keep improving our urgent pathways is a really good attitude.
No, well said, Glenn. And just again for members of the public, we do have the Foundation Group Improvement Week coming up a week after next to hunt out even more opportunities for us to improve individually and collectively. Robin?
Yeah, thanks, Chair. Just to pick up on a point you made about also a thing we didn't include, which was the work we are doing with the ambulance service. And we're working with them on a process called Call Before Convey, where we have services that they can access via telephone routes, and they then call ahead to see whether they need to convey that patient or whether we can give them advice, specialist advice over the phone to help a patient stay at home. So just a snapshot there of work that's ongoing with the ambulance service.
And that's a key piece of work. So I think, again, the numbers are, Robin, that when people arrive at ambulances, certainly I know this from the Worcestershire experience, about 25 to 30% of people arrive in ambulances actually don't need to have been conveyed in the first place. So that work is incredibly important. Simon Murphy?
Thanks, Russ, and thanks to Adam and Helen for that presentation. It's just really to echo what you were saying, Russell, about people who don't need to be in A&E situations. As you'll recall, we've had a number of visits from an independent expert, Mr. Sturgis, who's been to see Worcestershire. We've worked very closely with our ICB on implementing his recommendations about how we manage our A&E. One of those, which wasn't implemented by the ICB, was around an idea of an urgent treatment centre or a walk-in centre, which both Redditch and Worcester used to have walk-in centres. I just think we need to make sure that we're doing everything we can across the system and learning from each other across the Foundation Group to make sure that as many alternatives are there for patients who think they need to come to A&E, because, as you quite rightly point out, the fewer of them who don't need to be there, who don't come, the better for them, because they'll go to the right place. And certainly for our A&E departments, which tend to be very, very full. And I note Stephen had mentioned a little earlier that there is some work going on at our system level in Herefordshire and Worcestershire looking at this. So hopefully we'll get to some point where there will be other alternatives which would help. And some of us have been chirping on about this for well over a year, getting ready for the winter pressures we've just had. But just to re-echo what you were saying, Russell.
You're muted, Russell.
Thank you, Simon. Glenn, did you want to come in on that and then we'll move on?
Yeah, Ian Sturgis's report was really powerful, actually, as well as the opportunity for patients not to come to hospital. There was obviously the issue of patients who were in hospital who could be discharged straight home. So that's a really important piece of work. I thought it's quite interesting, though, when you look at the walk-in numbers across the 4 sites in the group, there's almost a kind of build it and they will come type approach if we're not careful here. That there's quite a lot of primary care activity, one could argue, going on at George Eliot and at Swift, different to the level of walk-ins that we're seeing in Wye Valley and Worcester Acute. So I'd be a little bit concerned about creating walk-in capacity that then just increases the total number of patients coming through our urgent care system.
Yeah, no, it's, in economics, it's called Say's law. Supply creates its own demand. Stephen, then we'll move on. Stephen?
Yeah, just a couple of thoughts. I think the bit with WMAS is really interesting, and I think part of this, the conversation we've been having, is kind of from their perspective. How does it work for them? So what is the incentive for the call before convey? Because perversely, if you give them a load of time things, you actually work against that. So we end up doing the wrong thing for the wrong patient. And I think we have to be really careful about the narrative, that it doesn't look like we're trying to pass it on to them or hand off a problem, and we've got to really work with them on that. And I think what's really interesting for me on this, when we talk about people coming in and particularly admissions, is if there's a lot of people or admissions that we think could be looked after somewhere else, how quick did we discharge them? Because that's the first bit. It's okay saying, actually, we think there was an alternative. So how quick did we do it when we admitted them into our beds? And I think for Helen and I, Sarah and the team, that's a big focus internally for us.
Absolutely, and that was in the Ian Sturgis report. I think just one of the things that concerns me about across both Hereford and Worcester and Coventry and Warwickshire is I can't recall a meeting I have been to as chair where West Midlands Ambulance Service have been there to talk about these type of issues in a developmental phase, that they're very much outside the ICB processes, which is a concern to me, which I've registered. Really good presentation. Thank you, everyone, for your hard work on that. We'll move on now then to the safe staffing overview and over to my CNOs. Not sure who's leading on this. Over to you.
I am, Chair. I'm going to start it off and then hand to my CNO colleague. So thank you. So let me share my screen. Can you all see that?
Yes, we can.
Hoping you can see the safe staffing presentation there. Yeah, okay, thank you. So just going to flick through the slides and then hand over, as I said. So the context, obviously, to safer staffing presentation for the public's benefit is that the expectation is that you have the right number of staff or ratio of staff with the right skills and competence and experience deployed to the right place to meet the demand at the time. But we need to balance that with the needs of the staff. So balancing getting the right work-life balance and the flexibility in their working patterns, and that's a complicated ask sometimes. So we try to reduce that complication and give an overview across the Foundation Trust of some of the key KPIs that we measure to identify whether we've got those right staff, right skills, and the financial balance actually, and patient experience, staff experience, and balance correctly. So the dashboard here shows Wye Valley, George Eliot, Swift, and Worcester's position with those key metrics. And overall, there's a reasonable, consistent figures in that, particularly across the care hours per patient overall, which is fairly consistent across the group. The patient experience and incident numbers are fairly consistent, and the fill rate and bank spend are fairly consistent across the group. The area that I would want to pick up from Swift is just understanding why there's a difference in vacancy position in registered nurses. That is higher at Swift at the moment compared to my colleagues. So I'm just doing some analysis on that. But otherwise, there's a fairly consistent picture. The second slide here just talks through those in terms of what you're seeing in that dashboard, and with us all flagging in our different slides the demand picture that we've heard in previous presentations around extra capacity and additional beds being needed through the winter period over the last quarter. The risk, we are sitting on a risk, particularly more so in some of the trusts, and this is certainly true for Swift, that the need to stop off-framework agencies, so that's the highest cost agencies. There's been a mandate to stop using those from July this year, which all the CNOs agree with. It's a waste of NHS money, but also really affects staff morale when some staff in a team are being paid significantly more than others. And so we are leading on that mandate. However, there is a risk, and particularly across the group, that's in paediatric services. So the vacancy position in most of our areas is fairly stable, but certainly in our paediatric services, they are higher, and we have been using those off-framework agencies to manage that risk to patients. So we're leading that, and we're going to mitigate that risk as much as possible. So for Swift, as I've said, the position in terms of our bank and agency usage and bill rate has improved, and particularly the amount that we've spent on nurse agency over the last year, but continues in the last quarter to be reducing. We are working as a system across Coventry and Warwickshire and I'm chairing what we've called a Project 1000 system piece of work to look at recruitment and retention of 1,000 more nurses into Coventry and Warwickshire system in over the period of 3 years, and we're on target to meet that. And then I probably just want to round up there and hand over to my other CNO colleagues. Thank you.
Thank you, colleagues. If I can just ask us to pick up the pace a bit, because there's a lot of detail in the slides which we have read. Lucy?
Certainly, very brief presentation from myself, Chair. So given this is quarter four winter period, similar picture to the previous quarter around the number of escalation beds up and the number of boarding patients, and just a generally busy hospital. There's some real positives in there, though, for us in terms of our really strong vacancy position. That will change slightly and deteriorate in the next report, and that's just because we've adjusted some of our nurse staffing establishments in line with changes in acuity. And also, you may recall at board last time we talked around that time-out provision that we make for people to be on annual leave or off sick was lower for our healthcare assistants than others in the group. We've now aligned that to 21%. So we will see a slight deterioration, but we've got a really strong performance now with recruiting healthcare support workers and registered nurses into our workforce. And as you can see in the pack, we've done really well on our sickness performance. We ended our year for agency spend reduction, 9.2 million we spent last year compared to 14 million in the previous year. So we hit our target, lots more work to do there. And especially, as Fiona alluded to, sort of not using framework agencies. I'm really worried about pressure ulcers. We talked earlier about comparing apples with apples. I don't think we are. I don't think we're counting in the same way. But it is a quality priority for us at Wye Valley. It's also a safety priority. We've got local service improvement plans and clearly some learning to do from Swift. Thank you.
Super, Natalie. It's Jeanette for Natalie.
Oh, sorry, Jeanette.
No, that's absolutely fine. So very similar picture that's already been presented at Swift and Wye. So our agency position has improved significantly, and I'm pleased to say that we are at 3.2% compared to the national requirement of our KPI to be at 3.7%. And we started off really significantly high at 9.5% at the beginning of the financial year. We've still managed to recruit, and our international nurses are all now here, and by July will all be counted within our nursing figures. However, our vacancy position may deteriorate slightly in Q1, purely based on our acuity reviews and our increasing of our capacity and opening new beds, which is very positive. The challenge that we will still have is that it's proving very difficult to recruit domestically from the UK for registered nurse positions, and despite us not using any off-framework agency since July last year, we do recognise that our risks are still particularly around our theatre, critical care, ED and paediatric service. And in terms of pressure ulcers, exactly as Lucy has already alluded to, it does look as though we're currently an outlier from there. At the minute, it looks as though we're not measuring equally across the area, and so there's further work to be done around that. And again, of course, we take all care and reduction in harms extremely seriously. Thank you.
Thank you, Jeanette. And then finally, Sarah.
Yeah, just very, very quickly from me, Stuart, sorry, Russell, is that
you can call me Stuart.
we are continuing to see a reduction in our agency spend, and this is because we are swapping out our agency staff, as we discussed earlier in our workshop session. Also, we're really focusing hard on reducing our off-framework agencies. Unfortunately, we have had some young people waiting tier 4 admissions, and we've had to bring in framework agencies for that specialist care. And I think we've heard how pressured the departments and hospitals have been through winter with additional capacity. We're really pleased about the standards of nursing care that we are seeing with really low rates of harm. So I'll stop there.
No, thank you, Sarah. And I would just like to, before I open it up quickly, congratulate everyone who's been involved in the international nurse recruitment. It is a great success across the FG. And as Jeanette said, there is a real challenge to get young people to want to come into nursing, but I can't emphasize enough what a great profession it is. And I'd just like to make one other point, because I've heard some very strange things about headcount reductions elsewhere. It is an abject nonsense, in my personal view, to limit the recruitment of nurses and frontline teams, doctors, healthcare professionals. We will do everything across the foundation group within our power to recruit substantive posts there. Agencies are bad, full-time substantive recruitment is good. When it comes to our overhead and admin headcount, we all need to challenge ourselves to make sure that we can justify every single head. But when it comes to frontline teams, we will absolutely support substantive recruitment. So with that in mind, any questions or perspectives? Glenn?
Yeah, the strength of that position overall, this is definitely the year to clamp down on agency use, particularly off framework. And obviously across the NHS, we're going to try and do that from July. So well done to George Elliott for getting there a year early on that one. I think a bit of a challenge to all of you on the acuity review issue. I find every time we look at this, it generally tells us we need more nurses, but I think the evidence shows that it's not just about numbers, it is about the relative experience of nurses. So to what extent do we look at the experience of the nursing team before we decide whether we do or don't need to increase the establishment?
Okay, just for time, I'm going to allow one person to come in this, and I'm going to look to Fiona. Fiona, what's your view on that?
We don't currently look at the experience per se. That would be quite, there isn't a model really in terms of percentage experience per team, but we do factor in the overall functioning of a ward, the logistics of how they run the ward, whether they've got a stable team, what their likelihood of recruitment is. But the demand and acuity of our organisations is going up, so it's not really surprising that the demand on our staff and the number of staff we need is going up. But we do professionally challenge it and triangulate with a number of other things other than just the acuity figure.
Okay, thanks. If any of the directors of nursing want to pop anything into the chat box, you're welcome. And finally, Jane, then we'll move on.
Whether we'd benchmark use of RMN one-to-one specials across the group, and it's something Lucy and I talk about frequently. And is it something that you've benchmarked, or is it something that we ought to look at? Because often that's where some of the Thornbury usage comes from.
Okay, so can I ask Sarah Shingler to come in on that? Sarah?
We definitely need to look at it, Lucy. But they, God, I'm not Jane. We're not managing to say with my names. Yeah, we do need to look at it, but it's relatively small numbers, Jane. But I think if there's something that we could do across the group to make us more sustainable, that would be helpful.
I knew I should have worn my name tag today for this meeting. Thank you, Sarah. It sounds like an opportunity for us. Okay, so thank you for that, team. I think the issue of acuity and experience is a very interesting one. It does worry me that, and it is very difficult, as you say, Fiona, to get a decent measure of how important experience is. But life experience tells us that the more someone does something, the faster they are doing it. So the amount of senior nurses in particular we've lost over the last few years, I think, is a general concern, which is why I'm so pleased with the retire and return work we've done to improve bringing back our most experienced nurses into the fold, albeit with less hours. We'll move on then to the implementation of the Sexual Safety Charter, and my Chief People Officers. Over to you.
Thank you, Russell. I will take this on behalf of all three of us. So this is really just to provide assurance to all 4 boards and the public around sexual safety in our organisations across the Foundation Group. By way of background, the Sexual Safety Charter was launched in June 2023 and builds on what was the Domestic Abuse and Sexual Violence Programme, which was launched in July 2022. And it sets out really clearly, which adheres to all of our values, that sexual harassment, inappropriate behaviours or misogynistic behaviours have no place in the NHS or indeed in our organisations, and those behaviours fall significantly below our values. All 4 organisations have formally signed up and are on the website showing that we have signed up to them. The Sexual Safety Charter looks and sets out a zero tolerance approach to unwanted and inappropriate sexual behaviour and misogyny, and sets the 10 principles which I've listed there in terms of how we create a safe and supportive environment for all of our staff. I can confirm that all 4 organisations have set out that they meet those 10 principles, albeit we note that we need to do more work to improve on the position, and there are work programmes in place in each of the organisation. I've included in the report the information from the staff survey. Members of the public and boards will be aware that this is the first year where a question about unwanted sexual behaviour was included in the National Staff Survey. It is also the first time it was included in the National Education and Training Survey. So overall across the NHS, we now have data on our colleague experience around sexual misconduct and unwanted behaviour. And what that tells us, that 1 in 12 of the workers across the NHS experience unwanted sexual behaviour from members of the public, and 1 in 26 members of staff experience that behaviour from other members of staff. This is across the wider NHS, and clearly there is a significant variance by sector and type, with a much higher prevalence of unwanted sexual behaviour in the ambulance and mental health organisations. We've listed there the percentages this year, and the 24, apologies, there's a typo in the report, the 24-25 priorities set out that each of the NHS organisations should sign up to the Sexual Safety Charter, as I've said, which have done. What I'd really like to draw the public and board's attention to is the work undertaken. We've tried to group that in terms of a thematic set of activities, because there is a lot of work underway in each of the 4 organisations around behavioural value frameworks, our communication campaigns, working with the Freedom to Speak Up Guardians, improvements in terms of policy, sexual safety policies, the Dignity at Work and safeguarding policies, and the huge amount of work in terms of developing resource packs, signposting, support for colleagues. So we can see that work goes through. And we continue with the work to improve the culture to eradicate any inappropriate behaviour. Colleagues and I are happy to take any questions, Chair.
Yes, thank you, Gertie. These numbers are horrific. 1 in 4 women have been raped or sexually assaulted as an adult. There are almost 80 people on this call. We haven't referred to it in this, but I think I know the number for Warwickshire is 1 in 10 women, adult women, have suffered domestic abuse or have reported domestic abuse. So the unreported domestic abuse would be much higher. These numbers are absolutely horrific. And I think it's really important just not to normalise the numbers. I was concerned at a recent Coventry and Warwickshire Health and Wellbeing Board, where that number of domestic abuse was sort of quite quickly passed over. And it is a horrific state of affairs where in 2024, particularly young boys and men don't realise what appropriate behaviour is towards other people. The numbers are horrific. So really great work on this. I want to ask a question, but I'll come back to that after Sue. Sue Whelan-Tracy.
Yeah, thanks for bringing this report. My point was very similar, Russell. It's a real opportunity to challenge ourselves and our teams around normalisation here. What I thought was very interesting was that it is more prevalent in the healthcare sector, these abhorrent behaviours, and so we do need to be proactive, as we are being with this charter, to say it can't happen here, and we have to support one another because we can see that it does. Thank you.
Yeah, no, absolutely. Can I just ask, if I'm and if we don't know the answer, we can find out the answer. Hopefully we know the answer. So if I'm a woman suffering domestic abuse and I arrive at the A&E, are there any known words or phrases that our reception staff know that if that phrase is used, that the person who's saying the phrase is subject to domestic abuse? Okay, so I can't see anyone's hand going up. Glenn?
And so in answer to the question, that safeguarding training takes place for all of our staff, particularly in those in areas like ED, and the ability to appropriately respond and refer and support individuals is absolutely there as practice, in particularly in the ED departments where it could be a case of people coming in.
Yeah, I'm just conscious, and I'll come to Jules in just a sec, but I know from my adult children that there are phrases like, if you go into a pub, if you ask for Eleanor, that means you're at physical risk. And I just wonder how well we are using phrases like that. The last time I came in, I saw Dr. Ashton, and people know to ask for Dr. Ashton as an example, and that is a red flag to our reception staff. Jules, I know you've got lots of knowledge on this. Jules?
It's a mechanism within triage, Chairman, for triage nurses to communicate with people that they think may be at risk, or to highlight how they can raise the alarm in a way that doesn't disclose that to anybody who may be accompanying them. I'm obviously not going to give any detail for obvious reasons, but yeah. Yes. Okay,
I guess, can I just ask teams to take this away? Because I'm not, I can imagine it happening individually, but I'd just like to make sure we're best practice on this. The numbers are so horrific that I want us to make sure we're doing absolutely the best we possibly can in this area when someone wants to be able to use a safe word or a safe phrase. I'll allow Grace to come in, then we'll move on. Grace?
Thank you, Chair. Apologies, team, for my lack of picture. Teams is not being kind to me today. I just wanted to raise, so absolutely on the code word, and there is a national scheme, Ask for Annie, but I also just want to raise, there's another issue around kind of code words that sometimes people might need to disclose that they're an abuse or domestic violence survivor, and it's really the luck of the draw according to whether that happens. So I've been in situations where I've kind of said, okay, I've survived this, I've said that, I need your help, can you please be careful with me, can you please tell me before you touch me? And no, it's ridiculous, come on. And then like it happened with our housing association. And they sent somebody who was very scary to repair something. I said, can you please don't send them again? They can't do that, he'll come tomorrow. And I was going over a size 5, I said domestic violence. I said, oh, domestic violence. I said, yeah. They said, oh, we've got a policy for that. Right, okay, you're on the list. We'll make sure nobody will come to your house without you knowing. We'll inform you beforehand. You can be, and unless I'd happened to stumble on that word, I told them what I'd survived. Unless I'd stumbled on that word, they wouldn't have done it. I've had it at the dentist. So right now it's only if you stumble on the word and that staff happens to remember that you might get treatment that you can actually tolerate, for example, at the dentist or in the hospital. So there's another kind of code word element that I'm seeing coming up a lot. I just wanted to ask, can we also think about how people say, I might need certain kind of treatment in a gynecological exam, etc. Thank you.
Okay, no, great point, Grace. Can I ask my CPOs to take it away? Because clearly, whatever we're doing at the moment isn't addressing the societal challenge, the quite clearly exists because the numbers are horrific. So if I can ask Gertie, Ali and Jeffrey to take it away and talk to your COO colleagues and CNO colleagues and just come up with a working plan that we can look at maybe in a few months, I'd be very grateful. But this is something which we need to be at the forefront of because it's a terrible situation. And I apologise if us dwelling on it in this part of the board has caused any personal trauma to anyone on the call, but I do want to make sure we take it as seriously as we should. We'll move on then to items for approval. The first is the annual review of board committee terms of reference. And Erica, I think you're leading on this for me, please.
Yes, thank you, Chair. It was a really good opportunity actually to consider and adopt best practice across the group, recognising that governance, irrespective of our different trust sizes and everything, is largely the same. We all have the same code of governance, etc. So this presents the charity trustee, the audit committee and the remuneration committees as a standard terms of reference. So we're all doing the same things in terms of that governance. For the quality related committees, there are significant variations. So I think for now we're going to leave those to be separate terms of reference. And then we are looking at aligning other documents, including possibly TMB and FMPE terms of reference as we go forward. So it's the start of just aligning all our governance arrangements and making sure that we're all doing the same thing and adopting the best practice where we're not.
Okay, that's great, Erica. So just in terms of formal processes, so we are here to approve the new terms of reference for the charity trustees. If you're not happy to approve those, could you please raise a digital hand? Okay, I think they're duly approved. The second was the audit committee. I think you said, Erica, if you're not happy to approve the audit committee and new terms of reference, could you raise a digital hand? Okay, duly approved. And then the final one is the nominations and remuneration committee. I always have a problem with that word. If you're not happy to accept those new terms of reference, please raise a digital hand. Okay, duly approved. And I think it's a great piece of work, Erica, so please just carry on with it. So we'll move on then to the group digital transformation update. Sounds exciting, Vicky. Sorry, Sarah.
Can I just, we also need to approve the terms of reference for the Foundation Group Strategy Committee, please.
Thank you, Sarah. So if you're not happy to approve the Foundation Group Strategy Subcommittee terms of reference, please raise a digital hand. Duly approved. Thank you, Sarah, for that. So we're then on to the group digital transformation update. And as I said, Vicky, sounds very exciting. Over to you.
Thanks very much, Russell. Thank you, everybody. So this report builds on the update that went to the Foundation Group Strategy Committee in Q4 last year. And it also, if I can just say, Chair, predates the presentation that Hack and Adam took to the Foundation Strategy Board last week. It was published before then and written in terms of a paper. So the specific frame of reference around business intelligence and informatics actually is now follows what we've got in terms of that group informatics presentation that went to that meeting last week. So please just bear with me in terms of the timing on that. I think it's really timely today, given that we've heard from Jim Mackey earlier, who describes about how we need to lean into technology, how we've got to avoid technology silos in terms of how we maximise productivity and we improve efficiency and also improve our patient and our workforce experience around that use of technology. Interestingly, this week, we've also heard that Dr. Tim Ferris has been welcomed back into NHS England. So Tim was previously the National Transformation Director, and he had a real focus on digital convergence and the benefit that digital convergence can bring to everybody. It's also important, I think, in terms of how we embrace digital initiatives to also support that gap around health inequalities. And we've also heard a lot about that today as we've been through the meetings. I'd just like to bring the paper to the board's attention. So this very much talks about how we leverage at scale the DDAP portfolio, so digital data and technology, across that whole family of functions and enabling functions for everybody. It talks about how we might work together and build on the work that's already been done specifically by the group's analytic board, but recognises the different levels of digital maturity that exist across the group. So we know, for example, that our colleagues at Wye Valley Trust were previously part of the Global Digital Exemplar programme and have a high level of digital maturity. And we also know that the Swift and the George Eliot Hospital will be embarking on a new EPR journey over the next few months. Meanwhile, Worcestershire Acute is midway through deployment of their EPR, and so far to date that seems to be going really well. So the paper articulates 5 frames of reference that we're going to work through in that DDAP portfolio space. So strategic digital leadership, business intelligence and informatics, digital applications, implementation optimization, infrastructure, which is resilient, and around that we're also going to talk about those convergence opportunities and efficiency opportunities, recognising that we have different delivery mechanisms across all of our organisations. And then innovation and engagement, which is really exciting. So we have 2 innovation hubs that exist across our foundation group, and we need to bring them and marry them together so we get the best of everything and we start to embrace clinical entrepreneurship in that space, and certainly working with Dan Carter around that particular piece and Adam, and bringing together those research and development colleagues that can support us in that place. The paper then goes to describe some high-level actions and timeframes, and the eagle-eyed amongst you will spot that some of that might have slipped slightly. This paper was written a couple of months ago, but there are things in train and things are working together as we move forward. Recently, we've also seen the publication of the Digital Maturity Assessment, and that's a national assessment that's come out over the last few weeks, and we've got a national deadline of the 13th of May to get that return, and that's over 480 questions that relate to digital maturity and digital capabilities across organisations, and that will form a really good baseline for us to be able to work and centre our investment around that. Recently, following the budget, we know there's going to be £3.2 billion available for NHS tech, and that's also set against that productivity paradox requirement, and we need to work together to understand how we can leverage tech to increase productivity. So it's here, Chair, I'm going to assume that everyone's read it, and it's here for approval, if I may.
Thank you, Vicky, and it's great to have your energy now being applied to this. I know we've had some necessary leadership change in this field, but we really do need to. We were ahead of the curve a few years ago on all of this, and we've sort of slipped a bit as a foundation group. So it's great that you're leading the charge to get us back to where we should be. So thank you. Questions or perspectives? Glenn?
Yeah, I'm going to say what you said as well, Russell. I mean, but thank you, Vicky, for your leadership on this. And just for clarity, this doesn't take away from the need for leadership within each of the trusts at executive level, but I think it's really important to have some coordination of that across group and to look at the ability to create a more resilient analytics arrangement across group as well. As Vicky mentioned, that 3.4, I think it is, billion is a really important investment in the NHS that comes from next year. So we need to be kind of ready on that. The maturity assessments will help, but we need to be ready to think about what we would want to do to increase productivity and quality as a consequence of making the suitable investments in digital. So I think it's a really good time to have some group-wide leadership in place.
No, totally agree. Jane?
Yeah, I really support that. I really welcome the paper and the strategic approach. As you say, we've got 11 months, haven't we, to get ourselves ready for the investment coming from next April, and we do need to be ready for it so we can get what we need. I had 2 questions. One you've partially answered, which is when I looked at the timescales, I was really worried about hitting them, and I think you've already said that that's unlikely. but the other thing the paper doesn't say is how these work streams are going to report back to all of the boards, and so how we make sure that we really do coordinate this. So I think it'd be really helpful, perhaps with the Trust Digital leads, to agree just that reporting framework so we know how it's going to work. That would be really helpful. Thank you.
Yeah. Thank you, Jane. Happy to do that. Thank you.
Okay, team. So we've all had the opportunity to see the paper, and as we said, it is our future. If you're not happy to approve, could you please raise a digital hand for me? Duly approved. Vicky, go and make it happen and lead the charge. Thank you. We've then got some items for information. The first is the Foundation Group Strategy Subcommittee report from the meeting on the 16th of April, which I'll take as read. Any questions on that report? Okay, thank you. So we then move on to the Fit and Proper Persons Test annual declarations. Sarah, I think you're leading on this, please.
Thanks, Russell. So as the boards are aware, the new Fit and Proper Person Test framework for board members was published in August last year. And this report provides assurance that all of the trusts in the Foundation Group are compliant with implementing the new framework. All board members, which that includes voting and non-voting board members, have completed annual self-declarations. And between Erica and I, we've undertaken all of the Fit and Proper Person Test checks for all board members. So therefore, this report is for the boards to receive and note, please. Thank you.
Thank you, Sarah. And my counsel all the time to board directors is declare everything, and then you're never at risk of embarrassment. Any questions or perspectives on what Sarah has briefed us on? Okay, thank you, Sarah. And we'll move on then to any other business. So any other business, please raise a digital hand. Okay, so we'll move on then to questions from members of the public, which I think we have a few. Sarah and Erica, which questions have we had?
Erica, do you want me to take this one as it's from a SWIFT governor? Yeah.
Happy for you to, Sarah. Yeah.
Thank you. So Roger Lloyd, who is a SWIFT governor, has submitted a question, and he says that there is reference in the deep dive on the urgent and emergency care in the SWIFT section to a private ambulance. Is SWIFT providing this service or using the service, and to what end? I think Harkamal's going to answer the question. Thank you.
Yes. So we have been using a private company to support us in providing additional ambulance capacity. So these are for patients who are ready to be discharged to their usual place of residence and where they need transport. So we would use the patient transport service that is provided by WMAS. However, we do know that they have been quite strained, certainly over the winter months, in terms of just how busy they've been. So we've faced some delays in terms of getting these patients back to where they want to be. So we've employed support from a private ambulance company who have been really beneficial to us in terms of maintaining our flow throughout the winter. So this is just a private ambulance company who come and take these patients home so they don't end up having a longer length of stay while they wait for transport.
Yeah, I mean, it's the phrase private ambulance, I guess, is the thing that maybe causes a level of confusion. It's more like a large taxi, isn't it, Harkamal?
A staff taxi.
Yeah. Thank you. We've got a couple of minutes and we have got a number of members of the public on the call. Elizabeth, thank you for your earlier feedback on your experience in the A&D. But in the chat box, any questions from other members of the public whilst you're with us? Elizabeth?
Sorry, it's not a question. Could I just say, adding on to what I said, twice you've sent my sister from Warwick back to her nursing home in the private ambulance because she's a stretcher case. And they've been amazing with her, Russell. She is poorly. And they've been wonderful. So the private ambulance has worked really well. Nothing wrong with WMAS, but I just need you all to know. Great care. Thank you.
No, that's super, Elizabeth. And, you know, frankly, we would prefer to use WMAS. but when they're not able to, the key thing is for us to do the right thing by the patient. And any other questions from members of the public who are on the line? Okay, then I'll draw the meeting to a close. Lovely to see you all. Next month will be the individual board meetings. We will be back together again in June, July, August for a 3 board meeting. So look forward to seeing you collectively all then. And can I suggest to my board colleagues we take a 10-minute comfort break and get together again in 10 minutes for the confidential board. So see you in 10 minutes. Thank you very much. Take care.